evening, depending on where you all are. My name is Wiltrud, and I am honored to extend a very warm welcome to all of you around the world. Together, we are now entering the second day, and into the second day. We have entered the second day, already the 11th session of this year's 2026 World Sepsis Congress. We are focusing on the universal care of newborns, children, and women in this Congress. As always, a big thank you to all the sponsors of the Congress who are making it possible for our community to come together. And especially for this session, we are thanking Sobi, who is the exclusive sponsor of session 11. Within the next hour, we will discuss technological innovations for neonatal, pediatric, and women's sepsis care, together with our 5 distinguished speakers from all around the world. We will hear about innovative approaches to using AI to enable early warning systems and triage, or to predict the risk of sepsis in emergency care settings. But we will also hear about ways to use telemedicine and teleeducational approaches to improving patient care, strengthen capacity, and improving the quality of services for those who need it most. For all of you, there will be an opportunity to ask questions after each talk. There will be 3 to 5 minutes time. All of our experts in this session are joining live, so for these undoubtedly too short 3 to 5 minutes of Q&A, I would encourage you to utilize the chat in our live stream. Thanks for joining, and without further ado, let me just introduce our first speaker to you in this session. I am welcoming Dr. Tallat Mahmood. Tallat is a medical oncologist and hematologist with more than 20 years of clinical experience in cancer care, and she's an active member of several professional societies in her field. Tallat initially earned a medical degree from Aga Khan University and then completed residency in internal medicine, as well as a fellowship in hematology and oncology in the United States of America. And today, Tallat holds the position of medical director within the Roswell Park Care Network at Ellis Medicine in New York. This is where she's leading efforts to expand access to high-quality oncology services and to integrating research and community-based care. And next to lung and gastrointestinal cancers, Tallat's interests lie within the areas of quality improvement, survivorship, and the integration of complementary therapies to enhance patient care. Tallat is driven by a strong commitment to advancing research and also improving the overall cancer journey for patients. Today, we are honored to have Tallat here with us, and we're looking forward to hearing from her about continuous temperature monitoring in oncology, seeing sepsis before it strikes. Tallat, over to you.
Well, thank you for that kind introduction. And thank you for inviting me to the 6th World Sepsis Congress. I want to talk about continuous temperature monitoring in the community oncology for, you may not know that Schenectady has a very underserved population, and it's very underserved and under-resourced population. And Ellis Hospital is right in the heart of this community. So when I was presented with this new device that had just been FDA approved, I thought, perfect. You may or may not know that cancer patients, besides getting admitted to the hospital with complications of cancer, they get admitted for infections. So sepsis doesn't start in the ICU. It starts several days before when no one is looking. Oncology represents one of the highest risk populations for sepsis. When we give our chemotherapy, these patients become neutropenic, and then they're at higher risk. certain cancers, such as lymphoma, myeloma, those diseases themselves are immunosuppressive, and then the treatments that we give are further immunosuppressive. And then on top of that, the white blood cell count will go down, the neutrophil count will go down. That puts them at way higher risk of sepsis. And women are actually much more affected for whatever reason by sepsis. In fact, 64% of women are overrepresented in the sepsis population in oncology. 30% of all hospitalized cancer deaths have been due to or in the presence of cancer. In the presence of sepsis. And cancer patients, as opposed to other chronic illnesses, are 10 times more likely to develop sepsis. And within the first 2 months after diagnosis, they are almost 8 times more likely to develop sepsis. So the standard of care at this time is to take the temperature. We tell patients, make sure you take your temperature at least a couple times a day. But, really that's not good enough. A lot of patients don't have a thermometer. They can't find it at the time when they're not feeling well. They'll only check their temperature when they're not feeling well. So really what we need is a device that will monitor temperature all the time, because these fevers are episodic that can rise and fall. Like I said, the patients are not really checking their temperature before they get to feeling not well. So it's more of a reactive process at this time rather than a proactive. And that's what we need to do, is to develop a proactive system. This also has downstream effects like ED utilization and hospital admissions, prolonged inpatient stays, treatment delays, and dose delays. And that leads to the chemotherapy that we give. And if we're having to dose delay and dose reduce, particularly in curable malignancies like breast cancer, lymphoma, this has been shown to impact the outcome. There's increased morbidity and mortality due to the sepsis. And by the time that the temperature is caught, the episode of sepsis has already begun. You may know that this is the fever or the initial signs of sepsis usually start about 72 hours prior to the event. This is what a normal temperature curve looks like. And once we start seeing fevers, the temperature increases are sort of episodic. And then they start increasing in amplitude. So there can be something going on before our definition of fever. And then by the time we reach the increased amplitude over 38.3, it is often, we are well into that 72-hour window where we can identify these infections or sepsis or these events early. And then this increases from baseline and is a sustained fever. So when it is episodic, often physicians, patients don't think much of it. Oh, okay, I took some Tylenol, it's gone. And then once it gets up to consistently staying over 38.3, that's when it leads to, it demands attention from the patient and from the healthcare team. So fever is a pattern. It's not just a number. So we need to look at what the pattern is and what our baseline is. So here's what we think that fever looks like, where it's a sustained increase. And this is actually what fever looks like. It's episodic. The amplitude goes up maybe once a day, maybe not even once a day. And we might check it if we tell patients to check it on a regular basis. Let's say they put an alarm in their phone that I'm going to check it at 3 o'clock every day. Well, they might miss these episodes where it's high. And sometimes patients feel chilled, sometimes they have symptoms, and they'll check it then, but sometimes they don't have symptoms. And especially in the elderly, they don't have symptoms. And sometimes the symptoms are that their blood pressure drops or something like that. So what we needed was some way of continuously monitoring the temperature. So when this, Sam came to when this device presented itself to the hospital, I thought, great, this is just what we need. So we designed a study to see how effective this continuous temperature monitoring was going to be in our cancer patients. Now, keep in mind that this study was done in sort of the low-risk cancer patients in that they had solid tumors, most of them. They weren't really being treated for those high-risk diseases that I talked about earlier. They weren't really being treated with the new types of bispecifics and CAR T cells where there's a much higher risk of temperature increase and infections. So the majority of these patients were solid tumors, getting standard chemotherapy, either doublets. Most people were getting doublets, meaning two drugs. So we set out to determine if 90-day continuous temperature monitoring with this temp shield could improve our clinical outcomes, enable earlier intervention, and was it scalable and economically sustainable. This is the temp shield. It's worn continuously. It's worn on the chest. It gives out the body temperature every 5 days. It's kind of like the most analogous thing I can think of is like the Dexcom that people wear for their blood sugar. It connects via Bluetooth to a mobile app in patients' phones. And then it connects to a clinician portal with the temperature being relayed into the clinician portal. So we put the alert threshold at 100.4 Fahrenheit. Once it was, and we decided to define it as if it stayed over that threshold for an hour during the daytime, And at night, because people were often covered up in blankets, we decided to make that 3 hours. So 24/7 monitoring. When there was a fever, it would alert the company that we were using to monitor this. And if they would then call the patient, confirm that they had a temperature, and then notify the on-call physician. So we did this study over a little bit over a year at Ellis Hospital in Schenectady, New York. People who were eligible was anybody getting oral or IV chemotherapy, could be any tumor type. We monitored them for a minimum of 30 days and a maximum of 180 days. The Temp Shield device, the battery lasts for 3 months. And so then it has to be changed out at that point. And we compared the group who used it against the group who declined to use it, because they didn't want to monitor, they didn't want to be continuously reminded, or they didn't want to put the device on, or they didn't have a smartphone, or whatever the reason was. So in the end, we had 148 participants. 85 wore the Temp Shield, and 63 ended up being in our control arm, who did not wear the Temp Shield or had low utilization of it. So what we found was that people who used the Temp Shield have had 75% fewer days, 52% shorter length of stay, and a 91% lower 60-day mortality. Looking at the raw numbers, the low utilization versus our control group, 26 patients had were in the hospital for 26 days, and the low utilizers had 76 days overall that they were inpatients. So even if you look at the raw numbers, anybody would say, whoa, that is very significant, had a p-value of less than 0.001. And as far as the mortality, we didn't have very many patients, but the 60-day mortality was only 1 in the people who chose to use the temp device, the Temp Shield, and we had 8 patients who did not who died who did not use the Temp Shield, and that had a statistical value of 0.01. So so by identifying infection early, by continuous monitoring, it prevents the clinical deterioration of an infection going into sepsis. So from bacteremia to sepsis. So that's pretty significant. So events that were caught by the Temp Shield, long-term monitoring, neutropenic fevers, as you know, a lot of times patients with cancer, we don't identify where the infection is coming from. But then we also had many UTIs, sepsis, of course, pneumonias, upper respiratory infections, soft tissue infections, and even some pleural effusions and thrombotic events. So identifying a fever through the temp shield was possible about 2 to 4 days before symptoms actually appeared. Now I'm going to go through some examples of, these are real patients, of what their temperature spikes looked like in the clinician portal. So this patient, for example, had colon cancer, a 51-year-old lady who had a temperature on the 12th, and then she didn't have a temperature again that day, that whole day, and then she had a temperature the next afternoon. So the 0 here is the time, and the 12 is 12 o'clock. So a full, let's see, 24, it was 36 hours later, she had another temperature spike. So this was at midnight. On the 13th, she had called me and said, oh, she just kind of didn't feel well. So knowing that she had had this temperature spike, I asked her to go to the emergency room. She went to the emergency room, but meanwhile, she had another couple of temperature spikes. So we had almost a 36-hour jump on her. She got to the ER. She met the SIRS criteria. She was admitted, started on IV antibiotics, and had a temperature the next day. And then after that, defervesced and did great, stayed out of the ICU. Another patient we had, a 74-year-old with pancreatic cancer. This patient was completely treated as an outpatient. She had a temperature spike here where we were alerted, not that the patient had taken her temperature. And then 2 days later, she spiked again. And then 2 days later, she had a couple spikes. So at this point, we called her and asked her to come into the clinic, tested her. She turned out to have a urinary tract infection. And that day, she had several more spikes. But by then, we had her treated, kept her out of the hospital. This is another example. This is a patient who was getting just immunotherapy, but even with immunotherapy, had a temperature spike, and turned out that she had a urinary tract infection. For most patients, we would call them the next day, work them up for an infection, where it could be coming from, treat them empirically. Some patients, such as this, especially if it was after hours, were asked to go to the urgent care or the emergency room. So you can see that this continuous monitoring was very effective. The temp shield had been compared to the oral thermometer, and there's a strong correlation or concordance between the temp shield device temperature and the oral thermometer device, whatever the oral temperature device was that the patients were using. So as far as the device itself, 91% of patients wore it and had no problems. 98% of the patients said that they would recommend it. So when we look at the current standard of checking your temperature when you feel unwell or once a day is really not adequate. It's a one-time reading. It doesn't mimic the the way that temperature responds to an infection. And it's driven by symptoms, whereas the continuous monitoring is proactive, it's passive, it's a wearable device, it's much more consistent with, I would say, 21st century care of oncology cancer patients on active treatment. So everybody knows that early infection detection saves lives. Every hour of delayed antibiotics increases the risk of death by 8%. And here we have shown that we have increased or we have been able to identify an infection a good at least 24 hours before the actual before the bacteremia turns into sepsis. So long-term continuous monitoring is actionable, improves the sepsis outcomes, and it's easy, very doable. Okay, thank you very much. And I'm happy to take any questions. This is my contact if you want to call me. I want to thank the patients and families at Ellis for helping me conduct the study. And I want to also acknowledge my co-authors, students, that was Mayor Pabas and Georgia Kaliki, and my physician's assistant, Alyssa Aragosa, and Elise, who was my nurse who was helping me with the study. Thank you.
Thank you, Tallat, Dr. Mahmood, for this impressive presentation, for your impressive work that you've done in cancer patients. I do believe that the data you showed in the beginning is already something that we always that we have to remember. You said that 30% of hospitalized cancer deaths have sepsis present, which shows the connection that sepsis has also to, you know, the big realm of cancer and how important it is for your patients as well, since your patients, as you also pointed out, are a risk group for sepsis. We have had in the chat a lively discussion about the reason why temperature actually increases and decreases in episodes. We have also had some input in the chat already why this happens in sepsis. From your perspective, could you add to that? Do you have an explanation why we have this periodic movement of fever in sepsis?
That's I think the physiology of the infection. I think when you get like a bacteremic burst, you know, that's when you get infection. That's when you get the body's reaction. You get the chills. For example, if a port is infected and you flush it, patients will get chills, and then that will trigger the body to mount a temperature response. So it's just the physiology of temperature is that it is kind of, it waxes and wanes until you get into sepsis, and then it's a persistent elevated temperature.
Yes. Okay. And you know, classic. Just one more question, maybe from my side, because I'm curious. Fever is always seen as one symptom of sepsis, and sepsis is, if it develops, it's a multi-parameter syndrome. You know, there's as you also mentioned, your patients don't feel well, right? There's like other symptoms as well, changes in consciousness nervousness and mental state, tachycardia, and so on. In the future, when it comes to wearables like the system you've been using, do you think that there are other parameters that would be useful maybe to add, or that would be helpful to have for patients like yours, for risk patients like yours, to be continuously monitored to avoid sepsis episodes?
Yeah, I think in addition to a temperature spike, there should be a bottom that if they fall below that, that should trigger us as well, because a lot of our elderly patients or patients who are very immune suppressed, they're not going to mount a fever response. And they respond by dropping their temperature. I would also like to see the
Yes.
pulse, the blood pressure. But, I think this is a great first step.
Yes, yes, obviously. I mean, yeah, these data are really impressive. I do agree. You know, in the SEERS criteria, it says that also hypothermia is an parameter to trigger an alert, and trigger a SEERS point. So hypothermia would be good. I agree to that. I don't think we can. I would love to ask some more questions. I think we have to move on to the next speaker, though. Thank you so much, Dr. Tallat, for doing this today and for giving us these invaluable insights.
Thank you very much.
The next speaker in the session is Juliet Kwadzodeh from Ghana, as I believe. Juliet is an executive nurse, nurse consultant, and healthcare quality improvement specialist with more than 2 decades of experience in advancing nursing and midwifery practice in West Africa, across all of West Africa, actually. Welcome, Juliet. Juliet is also the executive secretary of the West African Postgraduate College of Nurses and Midwives in Ghana. And she contributes to regional capacity building. She is busy in policy influence, and she is busy in professional development. Her work spans patient safety, digital health innovation, leadership trainings, and accreditation system strengthening in in diverse healthcare settings in Ghana, also Somalia, and others. She's also part of a fellowship program in sepsis, and she's concentrating on developing key performance indicators for quality of sepsis care in healthcare facilities in Ghana. Today, I'm more than excited to hear from you, Juliet, about your experience, and you're giving us a talk with the title From Vital Signs to Algorithms, AI-enabled early warning and triage for neonatal and pediatric sepsis in low resource settings. Thank you, Juliet. Over to you.
Thank you very much. Thank you very much for inviting me, and I'm happy to be here. I want to share my thoughts on vital signs to algorithms. So in my introduction, I am part of the Sepsis Fellowship Program, and one of my areas of work is for us to get quality indicators for the sepsis, quality indicators for sepsis. And in my quest to do that, I realized that there were a bit of gaps that I needed to close. So it brought about this particular discussion I want to put through. So in Ghana, many hospitals miss sepsis because we actually don't care, and it is also detected late. As I said, the quality indicator was one of the reasons why I actually saw this. And experiences from the West Africa, the East Africa regions, we know that there are real frontline constraints and shortage because of our migration issues. So those of us from Africa, West Africa, East Africa, we have peculiar problem with migration. So because of that, we have constraints at the frontline. So I put together a bit of systemic thinking, patient safety strategy, and also AI translators because I just wanted to solve the problem without necessarily needing a whole bunch of human resource to be able to get us the kind of care that we needed and also to prevent sepsis. So the future of sepsis in Africa will never be built on Silicon Valley. It will be built at the bedside. So we need a nurse-led intervention, which is powered by intelligence. So that is my motivation for actually taking an extra job in this. So let's talk about the problem. So this is a pilot project that I did, and it was an improvement project. So we are going to look at it from the project, what is there, and then also the solutions that we put across that was tested. So in the PDSC cycle, what was tested and how I intend to project it. So obviously from the previous presenters, we have heard that sepsis is a leading cause of death, especially in Africa, and we cannot run away from that. And recognition and delayed recognition leads to a lot of death. And in most district hospitals in Ghana, even the regional ones and the teaching hospitals, vital signs is recorded. That is what I saw. It is recorded, but the interpretation in time is where the problem is. If it's recorded, what we use it for and how we interpret it, the intervention, timely intervention was a bit of a challenge. So I realized the nurses were overwhelmed with the work because of the shortage, and early warning system was either absent or underutilized or not clearly explained and not clearly linked up with their daily work. So this is the reality in the low resource settings, inconsistent monitoring, high nurse workload, limited diagnostics, and also a paper-based system. So one of the things that ran across was the vital signs recorded on papers, and when we need to refer to them, it's actually difficult to trend them. So I was quite excited with the previous presenter's presentation because she actually got access to good trends, and that was a challenge for us. So what was the solution? I decided to work with a few people because we had to get something that was low cost, that will bring us a solution, use the early warning and then the triaging system to prevent sepsis in the first place. So from vital signs to intelligence, was one of the things that we had to work our heads around. It wasn't really an easy task, but we actually had to find a way out to get the nurses work done well, and also not too much stress with the number of staff that we had. So traditionally, you are going to record human race heart rate, respiratory rate, temperature, SpO2. I mean, it's recorded intermittently. So it's either 4-hourly, 6-hourly, 8-hourly, or 12-hourly. So there were gaps of recording. Now, what we wanted was a continuous data, and obviously the devices for the continuous data was difficult to get, like the cardiac monitors, the vital signs devices that were movable and can give you continuous recording. Infrastructure was another issue for us. So we had to get something else to actually solve the solution. So continuous data, pattern recognition, and predictive alert was what we were looking for. So we're trying to move from the measurement to a meaningful prediction, because that is what we need to give the patient care for the safety of the patient, and also to prevent the sepsis that we're looking for, especially in the neonatal area and then the pediatric area, because those ones were quite sensitive and very important for us to deal with. So the neonatal insights, one of the things that we realized in that area was a temperature instability, we have feeding changes, and we have subtle pattern deterioration. And these were things that were critical that we had to find solutions for. Temperature is recorded, but you cannot predict in the neonatal situation how the stability of the temperatures look like. So we really needed continuous monitoring. And also for the feeding changes, and so that will also mean that the deterioration should also be picked up. And so we had to find something just to make sure that we are actually solving a problem. So the neonatal use, we had to detect the subtle signs early. So the vital signs, we needed a way to understand the deteriorating signs. We had to figure out a way to get it quite early with all the constraints that we had, and also trigger early intervention and improve survival outcomes. So those were the goal for actually getting this particular solution. So let's look at also the pediatric triage optimization. So with this behind our minds, we realized that AI-supported triage at the OPD emergency unit, we had to put in some risk stratification. So in risk management, we have the low risk, we have the medium risk, and we have the high risk. So it was just color-coded red, yellow, and green, so that we are able to reduce overcrowding and also missed sepsis. So these are all vital signs check. So we had to color code some of them so that we are able to group the population of pediatrics so that we see which one needs urgent attention, which one needs intermediate attention, and also which one needs waiting, just monitoring. So we had to just color code them. So what were the early warning models? So the early warning model was the vital sign alert, the real-time analysis, the algorithm that will analyze the vital signs for us, and then the call to action. So these are the 4 major areas that we had to work with. And whoever was helping us to design the BPO person who was helping us to design the models, these were the basic models that we had to give them to work with. And because it was a nurse-led, we had to make them understand how the interpretation should be like, what kind of data we needed, and the real-time analysis, how immediate, what time should you get responses? So when you put in this and this and this data, the algorithm should be able to translate it to this and give the nurse the possible call to action, what actions we should take. Because in our settings, reference is either on a paper, or you have to ask your colleague, or you have to reference somebody's previous notes. And those were gaps that interfere with our work. So for the model for the setting, we decided to get a low-cost wearable sensor. So it was one of the things that we thought about really too, because we had to think about cost. So a mobile app was one of the solutions that we piloted with in a private institution. We had to use the manual entry with a mobile app because the low-cost wearable sensors were difficult for us to get. So we had to use the manual entry via the mobile app. And then we simplified predictive models based on the data that we had previous data that we had. And then we put in an action layer. So alerts the nurse, then we put in some protocols just to get the nurses to act on protocols. So we had to go through the standard protocols of some of the sepsis interventions for the early warnings course. So design for offline first environment. So our model was not looking at an online thing, because where we want the intervention to get to, internet will be a problem. Use of data for it will also be a problem. So we decided to work really hard to get something that is offline. So these are some of the tools that we try to use to integrate the warning score. So we aligned it with the WHO triage, early warning triage, assessment and treatment data, and then some mobile platforms, because it's not all the apps that could take some of what we were doing and also enhance the workflow. So we do a workflow, how it's supposed to go, which I showed you previously, so that the nurses will be able to get a straight way, which is not something that is so disruptive. So this was a simple systemic flow that we went with. So input the vital signs, and there will be an AI analysis, there will be a risk score, there will also be an alert. The nurse will review, the protocol will be activated, the treatment, and then the monitoring. So we realized that AI was one of the things that could help the nurses to be able to bring out solutions and also save life quickly. And so calculating the vital signs and discussing with your colleague and getting some of the interventions quite difficult to understand, we decided to put an AI analysis there to shorten the period of time that you will be able to think of an intervention. And then we just team it up with a risk score analysis. And then we also put an alert there. So at least with the color codes, the green, the yellow, the red, you are able to see which one. So when you get the alert, it's either red, a green, or a yellow. And that will tell you what exactly you need to do and how quickly you need to act. And the next review was quite important to us because AI can make mistakes, and we needed the professional to be able to align with whatever intervention that was coming through, irrespective of the protocols that was given. The clinical assessment of the nurse was quite important here. So the nurse review was also necessary at this point. And then the protocol activation, then the nurse will review and protocol activation until they are able to solve the problem. Then after that, we will be able to put in the kind of the quality indicators that we wanted to put in. So the importance of this simple system flow was to convert the routine nursing observation into intelligence and reduce the missed early sepsis cases, especially in the neonatal setting and then the pediatric setting, because it's quite unfortunate that when they miss some of these things, the outcome is not too good. So, and we don't have a lot of time in these settings. Standardized clinical responses was also another one of the importance for this particular simple system, and also empower nurses as decision leaders. And one of the things that our vital signs does for us is to take decision and actions on the patients to improve outcomes. So if you empower the nurses with some of these tools, they are able to confidently take a decision on way forward for the patient care. So this is an app I call the WSC Sepsis app that I tried to develop with the BPO people because we needed to get something to work with, and we needed to test some things and test the system and test the protocols. So this is a simple mobile app we are putting together. Even though we had to go back to do a few alterations to it so that it is quite usable, and how many people can go on top of it, and how much data it can absorb. So we want a real-time clinical decision to help nurses. This particular thing is geared towards helping the nurses because of shortage. So it is the temperature, the heart rate, the respiratory rate, the oxygen, the feeding, and then the liturgy level. So these are simple 6 vital signs that we identified that would help the nurses to actually take a decision on these pediatric and neonatal patients. And then the next stage is to give you, so when you submit it, it gives you an alert so that you see which of the scores you are getting. So I put a red here, but it can be green, it can be yellow, and then it will give you the next steps. And so when it gives you the next steps, then you can have a checklist to respond to it. So this is a simple app that we want to inculcate as a nurse-led initiative or solution, digital solution to solve the nurses' problem. So this is an example of one 3-year-old baby that we had to use the vital signs to do this. The nurse noticed that the vital signs in a 3-year-old baby is deteriorating. So the vital signs was 38.2, the heart rate was 165, the respiratory rate was 62, and the oxygen saturation was 89. All they needed to do was put the information in the app and submit it. The next thing we'll have to see was an algorithm, and then it will analyze it. So the risk score of the baby will be calculated, and the predictive solution will be to alert the nurse, reassess, notify doctor, prefer for resuscitation. So it gives you some simple, immediate actions that you could take on the baby to prevent this kind of sepsis. Now, these are some sepsis protocols that are already in the system that we use already. So these are some of the ones that we put into the system just to analyze the vital signs against the protocol so that we are able to get a good predictive analysis. So this is to whatever protocols we were able to gather together from the various places that we went to and put it at one as to what they will do when they have vital signs like that. So we put them together and inculcated it there. Now, the nurse validates clinically what should move forward. So what will the nurse do? She has to confirm the patient's condition. So she is standing by the patient. Even though we have put the figures into the app, we needed a nurse to also look through it and see whether it's commensurate with whatever is happening, and use clinical judgment and also decide with agency. We acknowledge that AI is a decision support, it's not a replacement, so therefore the nurse needs this. And then the escalation happens. So after this, the escalation happens. It depends on the severity, calling a doctor immediately, transferring to higher levels, or initiate the sepsis bundles. So these are a bit of escalation things. Some of them needed continuous monitoring, so the nurse will re-enter the vital signs and do every 30 to 60 minutes, and then the app will update the risk according to what is giving you. So here we were able to get some documentation. So that is where my quality indicators were useful. So time of entry and alert, time of response, time of treatment, and our audit and our sepsis audit. At least we were able to get some data now to be able to move forward with the quality indicator. So the call to action here now is that even though it was a PDSA cycle, we need to try it in different environments just to make sure that people are conversant with it, and it will work in different jurisdictions, because I wanted to finish my project, I needed to work on this specifically, but I need to expand the usage to see how it's going to do that. So we need an investment in a nurse-led digital transformation. We also need to develop the Africa specific AI models, and also integrate AI into our national patient safety strategies so that we'll be able to inculcate some of them in some of these simple actions that we take by the bedside. So as everybody says on the call of sepsis, early detection is the most powerful intervention for sepsis care. The future of sepsis care is no more data, it is just smart. So we have the data now. It's smarter, earlier, and actionable intelligence at the bedside. And I think that when the nurse leads on this, sepsis will actually be reduced. So I have a few acknowledgements, and my BPO company that helps us to do this, and obviously the Global Sepsis Alliance for the opportunity, Vixie Healthcare, and also the Medical Surgical Faculty of the West Africa Postgraduate College of Nurses and Midwives. So thank you very much for your attention. This is my contact, and you can actually reach me on this. Thank you.
Juliet, thank you so much for this wonderful talk. I'm very happy to hear about this work that you have been doing. In the chat, I have seen that there are already calls for you to collaborate, for example, in the field of pediatric surgical care. So people are already calling to say, oh, we need to expand this approach to other areas of care in pediatrics. For the sake of time, I will just ask one question. I think you've made a great case for the fact that the best AI-enabled monitoring is nothing without action. You know, you developed an algorithm where AI was used to create alerts, and then the essential thing for early detection and for treatment of sepsis is action. And this action is usually taken by nursing teams first and foremost.
Yes.
I wanted to ask you, as you're making this great case for that nurses should lead quality improvement in practice, and this is pushing it a little bit maybe, but I'm asking you, what does that leadership actually look like on the ground, and what needs to change in a health system, especially in resource-restrained settings for nurses to truly own and drive these quality improvement processes?
Thank you very much. I think that the leadership situation is quite, I don't know whether it's difficult or it's easier, because I want to be in the middle here, but we need more training in leadership, especially in quality improvement activities, to help us to develop some of these things, because the resistance to change is quite high in our setting, and mobilizing people around to actually see some of these things is also quite challenging. But what we need to do is to do continuous education and training in sepsis identification, and also use of digital tools and AI, which should be one of the priority areas. One. Number two, the policies that we have and the protocols that we have is quite rigid. So if we can come together and actually review them openly, discuss some of these things to help us to inculcate new things in the system to help our nursing practice, it will be quite good. And our decision-making table, we usually do not have a lot of nurses sitting in there. And so when the IT and are developing some of these solutions, they develop it in such a way that it gives us more work. Let me put it that way, because I have actually gone into a few EMR systems that didn't put some of these algorithm in there for us. So because of that, even though it's developed, it still gives the workload. And we have a lot of migration issues. So you don't get the nurses committed to completing most of the tasks. They will ask whether they should leave the bedside and complete the data in the system, or they should complete the data in the system before they get to the bedside. So at the decision-making table, they need some of us nurses to be in there when they are developing some of these softwares, to be able to help us to get around our work, especially our workflow processes, to help us to be able to give the patients the best of care. Thank you.
Thank you so much, Juliet, for this wonderful talk. We're moving on. Sorry, we're a little bit behind time, so I'm trying to be quick. I'm very honored to warmly welcome Professor Elizabeth Alpern. We are moving from the African context back to North America. Professor Alpern is an emergency physician and clinical epidemiologist and the division chief of emergency medicine, as well as the executive vice chair of the Department of Pediatrics at Ann and Robert H. Lurie Children's Hospital of Chicago and Northwestern University Feinberg School of Medicine. Welcome, Elizabeth. Elizabeth has vast research experience in the use of large databases to improve the quality and equity of care delivered to children. And her research also concentrates on epidemiology and treatment of emergency presentations of infectious diseases, including sepsis. She's the PI for the PCARN registry, a multi-center EHR database that explores quality of care indicators. She has developed an electronic health record, the PD screen registry, from which can be derived and validated, and I believe she's going to talk about this to us. Professor Alpert was also a member of the Pediatric Sepsis Definition Task Force, who developed the Phoenix sepsis criteria, which I think we are all familiar now with. And she has a passion for mentorship and supporting career development. So without further ado, Elizabeth, I'm handing over to you. You're going to talk about AI-based predictive models for pediatric sepsis and emergency care. Thank you.
Thank you. Thank you so much for that warm introduction and inviting me to join this great conference. I am going to speak about the derivation and validation of predictive models using machine learning for early pediatric sepsis. This work has been published this past December in JAMA Pediatrics, and there is the reference. And I want to acknowledge our funding from the NIH and ICHD. I don't really need to tell this group about why this matters. As we know, sepsis kills kids worldwide. That we know that delayed diagnosis equals worse outcomes, and that with delay in treatment, there's an increase in mortality and organ dysfunction duration, and that we currently have real important gaps in existing tools, and that there has not been prior multi-center models to predict sepsis before organ dysfunction occurs in undifferentiated emergency department patients. And so that was our goal in this work. We wanted to derive and validate machine learning predictive models of pediatric sepsis that allows us to predict, not identify, but predict organ dysfunction that occurs within 48 hours of emergency department visit using electronic health record data from the first 4 hours of care. And you can see our model here in green. There's our predictive interval that occurs with the data that is collected in the EHR in the emergency department. So if the visit of the emergency department is 4 hours or more, we will collect only that information in the first 4 hours. If the emergency department visit is less than 4 hours, we collect only the ED visit, as our goal was to look at predictive modeling in the emergency department only. If there is a discharge from the emergency department home, we did do follow-up to any return visits or readmissions within 48 hours. And you can see there that our predictive interval our outcome interval is in blue, with the inpatient admission up to 48 hours of care or a return visit within that time. The setting for this work is in the 5 PCARN health systems. We had 5 quaternary pediatric emergency departments and 3 affiliated, more community-based emergency departments in this group. We used a multi-site harmonized electronic health record data registry as our data source, and we included children 2 months of age to 18 years of age, so we did not include neonates in this work. And patients' visits were excluded if the patient visit resulted in emergency department death or transfer out of the system where we wouldn't have outcome information. Trauma diagnosis was the primary diagnosis, or sepsis was present during the predictive window. And that gets at what I was saying before, that our goal in this work was not to identify already occurring sepsis, but to predict sepsis that would occur within the 48 hours. Excuse me. Our time frame for the training of our models was 2016 through 2020, pre-COVID pandemic in the US. And then our validation began in 2021 through December of 2022. And for our features, we wanted to concentrate on patient and physiologic characteristics within the first 4 hours of care, not using characteristics of emergency department care that was provided, as that we thought would really indicate what the team was already thinking. Our outcome measure was Phoenix sepsis and Phoenix septic shock. Here are our sites. We did span through the United States. We spanned 2 of the most prevalent electronic health record vendors in the US, Epic and Cerner. And our data collection included comprehensive emergency department and inpatient EHR data, including demographics, clinical assessments, vital signs, medications, laboratory tests, imaging, lines and airways. We did have availability of the narrative notes, and then the ICD-10 diagnosis and procedure codes. We had more than 3 million patients visits in our electronic health record registry of patients aged 2 months to 18 years of age in our times of our test or validation data sets. About 736,000 were excluded, the majority from trauma visits, transfers out of the system, or sepsis that was identified within the feature window of the first 4 hours of care, or those that died in the emergency department. That left us about 2.3 million included visits, which we then split into 1.6 million for our training set and 719,000 for our test set. Our Phoenix sepsis criteria was determined in this group with those that developed it within 48 hours of care. And in the data set, in the training data set, our Phoenix sepsis criteria sepsis was 0.35%, and our septic shock prevalence was 0.15. That's very similar to what was also found in the test data set. And then you can see there on the right the range of sepsis and septic shock across our health systems, as some of our care areas cared for more complex patients than others. This presents information on our machine learning models, and what you can see here are the area under the receiver operator curve and the area under the precision recall curve for both sepsis and septic shock. Our area under the receiver operator curve for sepsis was greater than 0.92, and for our septic shock was greater than 0.94. Greater than 0.90, and that really indicates that we were able to have very robust models that were developed for predicting sepsis from this data. The precision recall curve gives you a more realistic sense of the challenge of predicting this very rare outcome. And as you can see there, on the graph, our dashed line in black towards the bottom of the graph is our prevalence of sepsis, and then our targeted sensitivity cut points are the X towards the right side over here. And you can see we have achieved above prevalence, but it does give you an indication of predicting of a very rare outcome. Here's that data. It's a little more easy to digest in numbers. And as you can see there, our area under the receiver operator curve statistics was actually quite robust, with our logistic regression meeting 0.92 and our XG boost meeting 0.93 for sepsis and 0.92 for septic shock. What's interesting, I think, in this graph is the most right-hand column, which talks about number needed to evaluate. So if we were to implement this predictive model in our EHR, we would evaluate somewhere between 45 to 68 patients, depending on which model we chose, for every patient that we would be able to predict had sepsis. These are the important features that were determined in our models. And as you can see here, the ESI, or the Emergency Severity Index triage category, was a very important component of the predictive models, along with age-adjusted vital signs and markers of medical complexity. We also developed the XG Boost model, taking out the ESI triage criteria to see if we could highlight other markers that were important for, or other predictive features that were important. And really, as you can see here, what became more evident was age-adjusted shock index, vital signs, and markers of medical complexity. This work did have limitations. Some organ dysfunction outcomes are influenced by care processes. So missing oxygen saturation may reflect the absence of respiratory distress, and that was something that we found was a predictive feature. It's a very complex model, so AI models of what we found and wanted to utilize are complex, and they're somewhat black box models that provide challenges for implementation, especially related to explainability and potentially acceptability by the care providers. Although we have seen in other work that very complex predictive models have been embedded in EHRs and utilized with a lot of uptake. Inherent to our rare outcome, there is the concern for alarm fatigue when we utilize models that have a large number needed to evaluate for every outcome. And therefore, variable cut points will need to balance sensitivity and false positives. But this work did allow every site to determine where they might want to have their cut point based on their population. And then our work does have a limitation in generalizability. We did conduct this in quaternary and affiliated community emergency departments in the United States that all utilize electronic health records, and that future work should include general emergency department settings and potentially pre-hospital settings as well. So in conclusion, using a large multi-center electronic health record database, to predict sepsis within 48 hours, we were able to come up with machine learning models to predict this outcome when not present in the first 4 hours of care. We also found that sepsis within 48 hours was a very rare outcome, and septic shock even more rare. Our findings illustrate the challenge of predicting this rare occurrence of pediatric sepsis in the emergency department before it has actually developed. And in further work, we hope to integrate electronic health record models with clinical judgment to help improve our test characteristics, and also look towards prospective implementation using implementation science. And so, you know, our overall conclusion is that machine learning predictive models for sepsis in the emergency department can identify children who have not yet developed sepsis and may be useful in future implementation. I want to recognize that this was a large collaborative work, and recognize my co-investigators as well as our funding source. Thank you very much. Oh, I'm sorry, you're muted.
Yes, I'm so sorry. I just realized. Thank you, Elizabeth, so much for bringing us this this work of yours. It's as you say, you pointed out in your limitation, explainability is not always. It's a limitation. Maybe it's a very complex model. Still, what I take away from this is that I see that your models perform extremely well statistically. But it is that the positive predictive value remains on the lower side, because luckily sepsis is a rare outcome in the population that you looked at. This is obviously a good news for your population. Since we are here with a global audience, and since the Juliet before also talked about the challenges in a resource-restrained setting, I just wanted to hear your thoughts on, since this is based on high-quality EHR data from in North American setting, if we think globally now, especially in settings without a robust digital infrastructure, what elements of your approach could be maybe transferable, and what would be needed to be maybe fundamentally rethought if we were to do similar work in a resource-restrained setting?
Yes, thank you. I think that one of our next steps is hopefully to come up with a more parsimonious model so that we can actually highlight fewer features that potentially achieve the same outcome of our test characteristics. So we're looking into models that are we able to get rid of some of our features and not actually impact greatly the test characteristics. So I think things like age-adjusted vital signs and shock index are going to play out to be very important. And those, I think, are going to be able to be implemented in a more in a resource-limited setting. The other difference, though, I think, as you point out, is it would be important. This is a predictive model in a very rare outcome in tertiary and quaternary care emergency departments in the United States. We would want to build a whole new model for a different environment because the prevalence of sepsis is significantly different in other environments as well. And so I think we may be able to utilize similar methodology and help with that in a different setting where our outcome is unfortunately more common, but we were able to hone in on those predictive features that we've already identified.
Okay, thank you so much, Elizabeth. For the sake of time, we will be moving on to our next speaker. I am equally warmly welcoming Dr. Shunsuke Takagi from Japan. Shunsuke is a specialized anesthesiologist, an emergency medicine physician, and also an intensivist. He has completed clinical fellowships at the National Heart Center in Malaysia and at the Department of Intensive Care Medicine at the Prince of Wales Hospitals in Sydney as well. Shunsuke is an associate professor and the chair of the Department of Critical Care Medicine at the Yokohama City University Hospital in Japan, and he is the head of the Tele-Intensive Care Unit Committee at the Japanese Society of Intensive Care Medicine. This is also what Shunsuke is going to talk to us about today. He has worked in his research on telemedicine as well as big data analysis, particularly using panel data and face recognition with video data for ICU patients in acute care medicine. And I'm excited to give the word to you now, Dr. Shunsuke. You will tell us some about the Japanese experience in setting up telemedicine. Your talk is titled ICU Anywhere, Telecritical Care as a Global Solution for Sepsis in the Era of Workforce Crisis. Thank you. Over to you.
Okay, thank you. Thank you very much for this valuable opportunity. My name is Dr. Takagi from Yokohama City University Hospital. Today, I would like to present our Tele-ICU system in Japan. So currently, our system is primarily designed for and deployed in adult ICU settings. So expansion to pediatric and maternal critical care is part of our future roadmap. So today I would like to introduce the existing platform and how it works in practice. So here is a core paradox. Sepsis affects 49 million people each year, killing 11 million, one death every 3 seconds. Yet the workforce to fight it is shrinking. By 2040, the ICU physician shortage will exceed 40%, and critical care nurse vacancies already surpass 50%. This is the urgent reality we face. So in pediatric and obstetric sepsis, time is critical. When children lack compensatory reserves and postpartum patients can then compensate without warning. Early goal-directed therapy must begin within 60 minutes. Yet in Japan, only 30% of facilities have adequate specialist coverage for around-the-clock critical care, and 87% report nursing shortage that directly limit bedside observation, creating dangerous blind spots for our most severe patients. So for solving this problem, we start Tele-ICU system since 2020. Instead of transferring the patient to specialists, we bring the expertise to the bedside. Spoke hospitals are equipped with portable monitors and cameras transmitting real-time vitals, video, and ventilator waveforms to a centralized Tele-ICU hub. The intensivists oversee the multiple facilities. So we create patient monitoring systems for Tele-ICU. So our device acts as a central hub, pulling together isolated data streams, EMR, ventilators, bedside cameras, and vital signs into one unified interface. So clinicians can view live waveform, patient video, alarm, and trend data on a single screen. So this multimodal synthesis is essential for detecting multi-organ deterioration, particularly in unstable populations such as sepsis patients. So key point of the patient monitoring system is a unified patient context matrix. It brings together 4 critical data streams into a single view. The first of the vital signs monitor, displaying a real-time hemodynamics across multiple patients. Second, live video stream. We can see patient conditions by the camera view. And the third, ventilator monitor with breath-by-breath waveform analysis, revealing synchrony and lung compliance in real time. And fourth, longitudinal trend records for 24 hours retrospectively. So these 4 layers give clinicians a complete, actionable pictures on the screen. So this is our actual patient management system in operation. So as you can see, it integrates patient video, vital signs and monitoring, and ventilator displays on the single screen. So compared to the 2 traditional phone consultants, so this significantly enhances information, enabling more efficient clinical communication. So importantly, it improves psychological safety, both the consulting and receiving clinicians. So now let's look at the results in Tele-ICU. So we connect in the 3 hospitals. So across 3 hospital sites in Japan, the introduction of our Tele-ICU system so delivered measurable improvements. So in sepsis mortality, site 1 saw a reduction from 27.6 down to 17.8%. So site 2 and site 3 also showed consistent declines. At the same time, ventilator days decreased at every site, most notably site 3. So the takeaway is clear: continuous remote monitoring and early intervention save lives and accelerate recovery. So to sustain Tele-ICU operation, we must rethink the mathematics of the healthcare delivery. Traditionally, outcome depends heavily on capital and labor inputs. But with the workforce shortage, this model is no longer viable. So technology, the multiplier A in this equation, is a key. So by liberating technology, we reduce dependence on costly human resources and build a sustainable system that maintains high quality care with fewer hands. So we are also applying AI for predictive safety using bedside cameras. We track the patient's hand and face position in the real time. So our proximity algorithm calculates the distance between face and hands within 5 minutes. So rolling window, generating a risk score update every minute. So when score exceeds a critical threshold, an alert triggered before cells expression occurs in the validation occurs. In validation, all 5 past self-expression events were successfully detected and in advances. Still, a few samples, so we have to improve our accuracy. So this is in our lab. So we are building an AI detection model trained on ICU data from over 500 patients and more than 25,000 hours of the image data during the ICU stay. So this model is designed to recognize early signs of clinical deterioration, so automatically and in the real time. So beyond AI, we are building ICU Anywhere, a plug-and-play monitoring system that works at any standard bedside with no special infrastructure required. So this lets us scale critical care to wherever patient need it. So this is our mobile Tele-ICU card designed for rapid deployment based on the continuous flow line concept. It integrated a PTZ AI camera for patient tracking, real-time vital sign, and the wireless transmission module. So this makes it ideal for sudden ER surge and the PICU, where permanent infrastructure is unavailable. So here is a hypothetical case illustrating real-time reassessment. A 2-month-old infant at the peripheral hospital deteriorates rapidly from RSV and sepsis. So through remote monitoring, unsynchronized breathing is detected, triggering an amber alert. The remote intensivist immediately advised the bedside team to reposition and end tracheal tube and increase sedation. So the infant stabilized promptly. Sepsis is not fire and forget. So this is my last slide. Our vision is ICU Anywhere for every patient and everywhere. So we are scaling hub and spoke networks across Japan, integrated AI-driven early warning system by 2028, and ultimately building the global network for low and middle income countries, because newborns, children, and mothers in rural or resource-limited settings deserve the same quality of sepsis care as those in urban academic centers. So telecritical care is not luxury, it is equity. So thank you very much for your attention. Thank you very much.
Thank you so much, Dr. Takagi, for your wonderful presentation. I have to say, I myself come from a German center that has a telemedical ICU, and I'm seriously impressed because I feel like I'm seeing the future when you're presenting your work. So that's very insightful. I'm happy you're here today to present this to us. I am also very impressed by your ambitious timeline and by your honorable goal to make this into a global framework also for low and middle income countries. And again, with a view on our audience here today, I would like to ask you too, what do you think in a health system that has far fewer resources than the Japanese or the German might have? If a health system like that wanted to implement a version of this, what would be the minimum viable tele-ICU model? What do you absolutely need, and what can you strip away for telemedicine in critical care?
You mean the minimum setting for the device?
If you could just your idea of what is the minimum that would be useful in a telecritical care.
So I think that different depends in the setting. So every patient is the severe, like university hospital, tertiary hospital. So we have to every bed in the need to the camera or the camera. But now in Japan, so many hospitals in Japan. So some hospital that doesn't have so many severe patients. Sometimes they care the severe patients. So telemedicine is not the 24 hours, not needs the 24 hours, 7 days. Sometimes the severe patient happen, so they wanted a consult and the specialist. So
Right.
that's why we creating the some mobile cart model. This is the more cheaper model. Yes. Because of the cost is the most challenges for the expansion, the Tele-ICU.
Yeah, I can imagine. Wow. So basically you're saying the audio-visual connection is essential. So a remote specialist should be able to see the patient, and it can also be run maybe not on a 24/7 basis, but on a consultation basis whenever there's a severely ill patient. This would be your two
Yes.
very minimal requirements for this system. Thank you. This is very
Yes, thank you very
interesting.
much.
Thank you, Dr. Takagi. We are have progressed in time. So as you might have noticed, I am rushing a little bit. I am warmly welcoming also our last speaker, Dr. Vanessa Denny. Vanessa is an attending physician in pediatric critical care at the Children's Hospital of Philadelphia in the United States of America. Welcome, Vanessa. Vanessa's academic and clinical work centers on advancing pediatric critical care delivery, not only in the US, but in international and resource-limited settings. She has led and participated in global health initiatives across the Caribbean, Central America, and in Sub-Saharan Africa. And her current research focuses on implementing a novel approach called Telesimulation and Telesimulation training programs to improve outcomes in pediatric septic shock across Sub-Saharan Africa. Vanessa is also interested in developing sustainable low bandwidth teleconsultation systems to expand access to pediatric critical care expertise in underserved regions like Sub-Saharan Africa. And she's passionate about strengthening sepsis care, which we welcome, of course. And she's also passionate about reducing global health disparities and advancing equitable critical care delivery worldwide. Vanessa, thank you so much. Today, you are bringing us your experiences in implementing telesimulation for improving outcomes from pediatric septic shock. The floor is yours.
Thank you so much, and it's such an honor to be here today, and I'm excited to share our work. I'll be just talking about using telesimulation to train our healthcare providers in low resource settings in the management and treatment of septic shock for kids. Just a disclaimer, the project that we'll be discussing was funded by the University of Pennsylvania and the Children's Hospital of Philadelphia. So as we all know, there's a global challenge with sepsis, and sepsis is a race against time. It kills not from a lack of knowledge, but failure to deliver timely care. There are a lot of known practice gaps and system constraints that a lot of our low resource environments experience. Now, why does this gap exist? It exists on a multi-level, from the national community level down to the hospital system, all the way down to the individual caregiver and provider level. So my colleagues and I at the Confanoche Teaching Hospital and at the KNUST Teaching Hospital as well, we really wanted to understand what the barriers are and what facilitators exist for children who are in septic shock when they're seeking healthcare. So we designed and conducted a qualitative study in 2024 to really sit down and understand what these barriers are. We interviewed all the caregivers of children who presented in shock through the ED, and also interviewed all the providers, including nursing, doctors, and trainees. And we found a multi-level existence of barriers and facilitators. But what was really interesting was there were a lot of barriers that existed within the actual hospital setting. And one reoccurring theme that came from this study was the need and the desire for more education and more training. So it's not that clinicians don't know what to do. The challenge is doing it fast and doing it consistently. So what's the solution? Yes.
Sorry, Vanessa, can I just quickly interrupt you? I'm just realizing you wanted to share slides, am I right? Because we're not
Yes.
seeing any slides at the moment. Maybe if you could, maybe something went wrong with the clicking.
Oh,
Sorry,
yes.
I just want everyone to see what you're talking about because I know it's amazing work.
Yes, I'll share it again. My apologies.
Okay. Thank you so much. I'm so sorry for the interruption.
No, thank you for interrupting. You should be
Please
able
go
to see
ahead.
my slides now. Yes.
Yes, we are. Thank you.
So as I was saying, there's multiple gaps that exist within our low resource countries, starting from the national community level, the hospital system, and down to the individual level. My colleagues and I conducted this study in 2024, where we conducted a qualitative interview where we really wanted to understand from the providers and the caregivers why these barriers exist. And one of the most interesting things that we saw was that there was a need and desire for more education and for more training. So it's not that clinicians don't know what to do, the challenge is doing it fast and doing it consistently. So the solution that we came up with as a team was innovation by collaboration. So we decided to collaborate with our colleagues in Ghana and also at the University of Pennsylvania and the Children's Hospital of Philadelphia to develop a hotkeys telesimulation training program. So what's cool about this remote telesimulation program is that the training doesn't require resources that we don't have in these environments. It's remote, content exports can beam directly into the local wards. It's low bandwidth and engineered for areas with unreliable infrastructure. It's real time, so it's immediate debriefing and live feedback loops. And what makes this special is that it's contextualized strictly and tailored exactly for the needs of the environment that you're working in. And so just a quick example of what this looks like. So basically we present a case, we present vitals, we walk through it with the simulation participants, and we produce a clip of a child that presents in shock with the caregiver consent. And we walk through the case together. That's filming clips of children that look like the population that we're training in and also in the environment that we're working in. So we really wanted to know, like, does this work in real life and how will our children be affected by this training module? So we recently published our data and we did a single center prospective study looking at the use of this telesimulation program. We hypothesized that this contextualized unique program will not only improve the time critical interventions in simulated patients, but also in real patients. And not only will it do that, but it will also hopefully improve our mortality outcome and will be seen as acceptable and feasible in our environments that we're working in. So for our study design, we had a patient that would present in shock based off of our institutional screening criteria. We then did 6 months of baseline tracking, really looking at the time it took to provide the 8 time critical interventions. We then spent and trained our providers twice using this REACH intervention, which consisted of 30-minute low bandwidth telesimulation clips. And then we went back again to see if our process of care improved. These are the 8 steps that we looked at during the simulation. We looked at when and how they were identifying shock, initiating access, blood cultures, fluid boluses, reassessment, and antibiotics. So we had a high implementation, acceptability, and feasibility. 98% of our providers found that this program was not only acceptable, but feasible in their work environment. And after we trained them twice, we found that we had a significant improvement in our total score of the simulation. So now when it comes to real patients, these are the steps that we looked at when we were trying to see how our patients who presented in shock were treated. We also conducted and documented all of their hemodynamic parameters up to 3 hours of arrival time. So these were our final results when it comes to real patient impact off of this telesimulation program. We had a significant improvement after our simulation program of patients getting oxygen. More patients were able to get IV secured and had it done faster. More patients who had more thoughtful decisions when it came to providing fluid boluses, but every child who got a fluid bolus was reassessed after our intervention. And the ultimate outcome, translating this training to survival, we had a massive improvement in our morbidity rate. Pre-intervention, we had a 35% mortality rate, which went down to 10% after this intervention. So really from one center to the world, this is a proven bridge. Telesimulation is no longer theoretical. It's an empirically proven, resource-efficient bridge to deliver this highly contextualized expertise to environments that are facing the greatest systemic friction. And this action is scalable. It's very scalable to all children and to many environments throughout the world. Our vision is to create sustainable and scalable pediatric critical care training, extending outward from Kumasi, Ghana to equivalent resource-restrained clinical settings worldwide. Thank you so much.
Thank you, Vanessa, for bringing this wonderful work to us. I have two quick questions maybe for you, because you mentioned the contextualization that you're doing in your work, and we have seen that you've been doing this in several contexts now. Can you explain what that means, contextualization, please?
Yes. I believe strongly that whenever you implement any program in any environment, you want to make sure that it's specifically tailored for those that you're treating and those that you're training in this instance. So what we made different about this simulation program is that each video occurs with the children that they actually see in their local region, and it occurs within their emergency department or their ICU, which has all the resources they have. So we have clips of children getting IV access. So it's all the catheters that they use. We have all the types of oxygen support that they use. So everything becomes familiar to those that are being trained, which helps retention of knowledge and implementation of these resources in real patients.
Okay, that's wonderful. It's also, it seems like it takes, you already in the planning of the training involve the people that you're going to train, right? Because you go to the context and you contextualize your videos and your simulations, which is, I think, a wonderful characteristic of what you're doing. My second question, and also the last question for this session, is a little bit of a closing one maybe, because my feeling at this point is that across everything that we've heard today, we've heard about technology, about AI-enabled triage, about big data sets and prediction of sepsis, telemedicine. Your work focuses on people, and it focuses on teams and training. What is your opinion? Are we still underestimating how much of sepsis outcomes still come down to training and teamwork?
Definitely, that's a great question. I think we do, and I think this is why studies like this are important, to really show that how much of a difference training and teamwork can make in the total outcome of our children who survive sepsis. So I think, collaborating with our local providers and really, coming up with research that can show and prove that more training actually overall helps real patient outcomes.
Thank you so much, Vanessa. Thanks for this last answer. I am going to close this session now. We've been a little bit over time, but I want people should have the option to jump onto all the other interesting sessions that are following this one. I want to quickly thank you as an audience for joining this. I want to encourage you to visit the website, look at the World Sepsis Declaration, sign it. Follow us, the Global Sepsis Alliance, on Facebook, on Twitter, on Instagram, on LinkedIn, on TikTok. Keep in touch. And again, at the end of the session, a kind thank you to our sponsors, especially for Sobi, for uniquely exclusively sponsoring this session. The session will be available from YouTube for everyone to rewatch. Thank you so much. Have a wonderful rest of the day, and see you soon again.